So let's score it while I'll show you sketch as well. Overall, the consultation was good. She was very polite. Tone was very polite. I was feeling very safe as a patient in her consultation, and she was trying to help me out. She met the criteria. She has given me antibiotics, and she diagnosed this straight away. But few questions I would like you guys to. So after that,
I'm telling you, I missed some very important questions.
Headache, because it's a very common presenting complaint in the A&E setting. So I'm very good at that. I'm not saying I'm very good at doing it, but I would say I have created some of the scenarios. So I want to discuss with you guys. So all the scenarios together. So let me share that screen for you guys.
Just a question.
Yes.
I noticed in Dr. Zahra's consultation that she was very polite. Her communication was very good.
Yeah, definitely. She is very polite. Yes, definitely. She's very
but
polite.
As you said, and as Dr. Zahra said, that some questions were missed. But I think that was because of the time, and 8 minutes are very less to cover all the questions. So can we cover everything, like every question, but on the expense of communication?
No, let me tell you, this is PLAB 2. I know it is very highly competitive exam. Zahra passed her exam. Now she's a practicing doctor. She might not ask all the questions, but you are in PLAB 2. How would you ask all the questions? Because you have to pass this exam. You know, driving on the road is easy, but passing driving test is not easy. I'm telling you, in UK, passing driving test is not easy. Once you pass it, nobody cares how you're driving it, how many tickets you got. So this is what once you get a GMC registered doctor, definitely you would be safe. You'll be trained yourself again and again. We call it CPD appraisals. You will know your deficiencies and you will improve on. But PLAB 2 exam is highly competitive.
But my question was that what if you focus on covering every question, and in the process the patient feels unheard and you fail eventually, so even if you cover every question?
Zahra didn't fail this scenario, number one. Number two, I'll coming to the point. I'm gonna show you that algorithm which is covering every headache which you might see in your real life as well. And in the meantime, I'll also debrief what the Zahra has done, what she can improve on. So from my side, does the consultation meet the criteria? Yes. But where the things are lacking, we'll discuss. Because after discussing that protocol, Zahra would be examiner and I'll be doing as a patient. So she will be giving any scenario out of these headaches, which I'm going to give her now. So I'm going to share my screen now. You guys able to see the screen in 1 minute? Just give me 1 second. So that is basically, trust me guys, if you put focus on this sketch and put focus what I'm telling you guys, you will never ever misdiagnose any of the headache. Okay, so everybody can see this now. Everybody can see this sketch.
Yeah.
Well done. So let's go to the headaches. This is the sketch which took me many hours to create this sketch, this algorithm. So I will tell you everything about the headache. So let's start with the history of presenting complaint. I want your focus. Saban, I want your focus. Okay, Pinky, everyone, I need your focus. So somebody is going to say, doctor, I'm headache. First thing is that you will acknowledge that I can see that you're having headache. Then after that, you will see the Socrates. So can you please tell me more about that? Where is the headache? Can you point out with the finger where is the headache? So in the sinusitis here, and how does it started? It started suddenly or gradually, because you need to rule out subarachnoid hemorrhage. When it started, how long it started? It started suddenly or gradually. Describe the pain for me. Can you tell me how the headaches feel like? Is it dull? Is it sharp? Or something like that? Is this stays every time here, or sometimes you feel relieved? Anything seems to make it better? Is this headache stays here? Is moving elsewhere? Is pain change? Rara, you want to ask anything?
Yeah. I just need to leave. I just texted you as well. Sorry.
Okay. Yeah? That's fine. I will discuss with them anyway.
All right. Thank you so much. I'll join you back in 2 hours. Thank you. Bye-bye. Right. Bye, everyone.
Bye. So now coming to the point again. So pain change over the time. Anything make it worse or anything make it better? So give options. Like what doctor? Like Zahra didn't give me. Now she's not here. I can tell what she haven't done. So she's okay. So can you tell me anything make it better or worse? Like what doctor? Like when moving forward? Yes, doctor. When I move, oh yes. When I move forward, it make it worse. And you'll give option. Can you please scale it for me from 0 to 10? Ask for that how much pain relief you give taken. Then you will ask, is this headache, the option, what option you can get? Is this headache is a band like, because if the age is young, the patient is going through stress. Is this headache unilateral? Migraine. Is this headache unilateral? Migraine. Is changing position help? No. Is changing position make worse? Is this headache on the face, going on the face as well? Okay. What type of headache can go on the face? One is this one, sinusitis, and other headache on chewing that can go on the face as well. Trigeminal neuralgia. Okay. And then you will ask, shaving, electric shock like, worst headache of life, like a banging headache, moving forward make it worse, pain on chewing or shaving, around eyes, worse with exertion or sex. What it is this? What is this? This headache is basically intracranial pressure, raised intracranial pressure. So that worse with exertion or during sex. So this is one of the emergency as well. So you can even say that, is your headache get worse with exertion? Is your headache get worse with the movement? Migraine can be that word. So these are the few things you can ask. This is the maximum thing you can ask. Now coming to the DDs. So fever, why I'm starting with the fever? Why I'm starting with the fever? Fever because I'm trying to rule out meningitis, because meningitis itself is a headache. Okay, so fever, problem with the light, neck pain, any rash. Do you feel sick? These are the questions. Do you feel sick? So early morning vomiting. What I'm vomited? What does that? I'm trying to ask through tumor. I'm trying to ask tumor. By any chance, early morning vomiting or floss, fever. Again, the same thing. Fever, lumps and bumps. You can ask about that, but you don't need to ask lumps and bumps. You can ask about appetites because you want to rule out tumor or cancer as well, because the headache do have tumor due to headache, T for tumor, T for tension. So these are the few things you need to know. Problem with the walking or balance, that is another sign of having tumor with headache. And fast, any fall. Fast, what are the fast? Again, any facial or arm weakness, any slurry speech, any fall or bang your head, ongoing stress, any cooker problem. What I'm trying to ask? Is your home have any cooking problem, cooker problem? What I'm trying to ask? Guys, chat box. Yes, Dr. Noor, not enough DDs. So you can see that how many DDs at the moment I'm doing. Thank you guys. Thank you, Dinky. Right, I'll come to that. Carbon monoxide poisoning. Thank you, Mo. Any problem with the heating system or cooker? Because you want to rule out, it's very common in UK. And add skin changes as well. Any skin changes, any red skin, that is a late sign of carbon monoxide. Bloody vein. Bloody vein can tell you different thing about cancer. It can tell about eye problem. It can tell about glaucoma. Why I'm asking red eye or eye pain? Glaucoma also give you headache. Okay, eye problem, red eye. In female, period. So she was the female, I was the female. So she didn't ask about headache. So I'm going to tell you why. When somebody says, yes, doctor, when is my period is nearby, I do have headache. What is the diagnosis, guys? Give me diagnosis, guys. What is the diagnosis here? Guys, give me diagnosis. Saban, write in the chat box. Hasham, open your video. Hasham, if you're not at work, try open your video. Yes, Hasham, how are you?
I'm fine, sir. How are you?
Thank you. Premenstrual syndrome. Okay, so Hasham, never ever forget, because there is a scenario in which you need to ask about periods. So because if it is related to the period, it could be what we call it menstruation problem. Saban, can you turn on your camera as well, because it should be more face to face, because we need to be interactive. Saban, can you turn on your camera if you're not at job, or whenever it's possible you turn on your camera? Okay, I highly appreciate, guys, if you turn on your cameras. I want to make this session interactive. PLAB user exam of talking, getting your fears out. Just when you will be walking in your exam, just tell that here you are a doctor. They will see my skills. I went to medical school. I've done everything. This is the time to show my skills. So happy face, smiley face. Okay, practice smiling now. Good. So here, why I'm asking muscle aches. Why I'm asking muscle aches? Any pain in your arms or hips? What I'm asking, what I'm trying to ask. Yes, Radha, what I'm trying to ask.
Fibromyalgia.
Sorry?
Fibromyalgia or something. No?
Yes, it could be, but related to the headache. Guys.
Weakness in your arms and legs.
No, weakness. I know there is a lot of doctors know that what I'm trying to ask. Fatima, do you know what I'm trying to ask? Bismarck, what I'm trying to ask. Guys, I know you know that. Why I'm asking, any muscle stiffness or pain in your hips or Big muscles pain? Guys, please tell me what I'm trying to ask. I'm asking a complication of PMR, GCA, giant cell arthritis. It's written, it's a big written, it's give you temporal headache. It's give you temporal headache. So that is one of the scenario in the PLAB 2 as well. It's one of the scenario in the PLAB 2. Okay, well done, guys. Good. So let me calculate number of DDs which I've done here. Meningitis, yes or no? GCA, yes or no? Tumor, yes or no? What else I have done? Tension headache, yes or no? Carbon monoxide poisoning, yes or no? So here in the top, Socrates, what was the DD? In the Socrates, we done the DD of sinusitis. So I have done 6 to 7 headaches straight away in Socrates in this part. You agree with that or not? Eye pain, I've done glaucoma as well. Now, this is the point where you will be doing the general background, that is psychosocial. So in different headaches would be different. I'll be covering all the headaches together now. General background, psychosocial, mectosa. So you always signpost, okay, thinking about your general health. So can you tell me, do you have any allergies? So guys, type in the chat box, type in the chat box that what is the most important thing in the mectosa that you would ask if someone is coming with headache? What is the most important thing you can, guys, I missed one thing in the DDs. Can you tell me what I have missed? Family history. What the family history will tell? You have to answer, Hisham, now. Hisham, speak. What's the family history will tell? Occupation. You have to give me answer as well. Hypertension, do make sense. Subarachnoid hemorrhage. Polycystic kidney, not related. I don't think so. Specifically related to the... Guys, please come to the... Yes. Medicine. So in the general background, I skipped head injury. You should have asked by any chance you hurt yourself. You banged your head. I didn't ask. So that can give you headache as well. Trauma, that I should have. But in mectosa, medicine specifically, you can ask about any of the antibiotic which can give headache. Number one, and any of the medicine. Then allergies, not very important. Family history is important with the tumors. I'm sorry to alarm you. You will say that. I'm sorry to alarm you. By any chance, do you in your family there are any history of tumor or cancer? You will signpost that. Mectosa, O for occupation. Yes, occupation is very important. Yes, we told occupation because he would say, yes, I'm a manager. Recently promoted to the manager. Stress increased. Stress increased. So you got headache. Stress increased. Well done, Fatima. Well done. So this is what I want to ask. Hangover headache. Because if you miss mectosa, another example of mectosa, not missing mectosa. If you don't give respect to mectosa, the PLAB 2 will not give you respect as well. So alcohol. Zubda, can we skip alcohol history?
No, I don't think so.
It's a hangover headache. Hangover headache. Yes, it's a separate scenario. Carbon monoxide is a separate scenario. Alcohol is a separate scenario. GCA is a separate scenario. So all the DDs are separate scenarios, which we have done up to now. Meningitis is a separate scenario. Well done, guys. Now, promotion, work stress is a stress headache. Okay. Well done. So you are doing good, guys. Now, communication 2. How to ask? How to ask? Hisham, please turn on your camera. Ask me about my headache. Do ice. Just read it from the slide and ask.
Have you given a thought? That's what's happening to you? How? What's the reason behind this?
Doctor, yeah, I'm thinking I might be having a tumor.
How do you know that? I mean, have you done some? Have you gone through some kind of investigations, or why do you think like that?
Because my aunt had that problem. That's why. All right. Ask expectation.
Anything you want me?
Yes. Anything specific
you are expecting?
I want CT scan, doctor. Thank you very much, Hisham. So this is how you will ask ICE. You will improve on when you practice. Well done, Hisham. So now is when you will be doing the headache examination, what things you will be doing. Again, I will take your obs, especially your blood pressure. I will check front and back of your eye. I will touch, feel your neck, and I will feel your temporal area. I will feel your temporal area. I will check the nerves of face, legs, and arms. I might do the CT. When you will do the CT, you will do the CT in the subarachnoid hemorrhage when you are suspecting. If sinusitis, in some cases, when the patient is very unwell, you will do that. sinusitis infection, otherwise not. So now coming to the point, so we'll manage separately everything. So management of migraine. If somebody is going to have a unilateral headache, after that I'll show you scenarios, guys. If somebody is going to have a unilateral headache, she is female, 17-year-old, unilateral headache, and she also have a problem with the light. Is this migraine? No, it is photophobia can come up in the migraine. Yes, it's a migraine. It's not meningitis. So she would say, I'm having migraine. Doctor, help me. If it's a A&E setting, you would start. If you don't have any asthma, you will ask, do you have any previous? Because then you give 900 milligram aspirin. Or she already have. She would say, doctor, I already took the paracetamol. She would say, I already took the aspirin. She would say, doctor, I don't know. Then you will do subcut triptans. Oh, okay, I will give you one injection through your fat, or I will give you one injection. We call it subcut triptan. Now, if it's a A&E setting, if not A&E setting, then you will ask about the prevention treatment. So you will give, if it's a GP setting, you will give a nasal spray of triptans, nasal spray of triptan in GP setting, or you will ask GP to give preventive medicine for that. In menstrual migraine, so if the patient is having migraine related to the menstruation cycle, the order would be the same for the treatment, but you will start with the paracetamol, you will talk about aspirin, you will give triptan. If patient is telling you, doctor, I'm having headache, which is not relieved by any of these medications, then what you will do, you will give the top of the medication, you will give the next one, and you will mention prophylactic medicine through GP. If A&E setting, through GP. If you are in GP setting, you will say, okay, I will give you some prophylactic medicine, prophylactic or preventive medicine. So that, and I'm sorry, bless you, I'm really sorry you're going through a tough time. You're a brave girl, you have too many episodes. Can't we give oral triptans for more than 19 years? Here, usually we go with the subcut triptan. We do give oral one as well, more than 19, but it's better to give with the subcut triptans or nasal spray. Cluster headache would be have the similar presentation. Again, that the GP would give the prophylactic medicine, sumatriptan and nasal spray with onset of headache can repeat after 2 hours. You will tell about that. And after that, you will tell the patient that if you are in the A&E setting, you can give subcut triptans. Okay. And sometimes if somebody is having cluster headache, it's a very bad headache, it's similar to the migraine, it's 10 out of 10, it's not helping. The patient would be crying in front of you as a GP, or they would tell you, doctor, I have tried everything, that you would say, I might need to refer you to the neurologist. So you will say that I might need to refer you to the neurologist. This is what the treatment. I'm repeating it again. In migraine, young patient would be coming many episodes of the unilateral headache. Photophobia would be positive. So treatment management would be what examination would be you would be doing. You'll be checking the front and back of eye. You will be ruling out other things like subarachnoid hemorrhage or something, and you will treat him from the start from the paracetamol, ibuprofen, aspirin, 900 milligram in the A&E setting. Otherwise, if it's a GP setting, if the A&E setting, IV fluids, if GP setting, give subcut triptans, no, or nasal triptan. Okay, so this is how you will manage migraine. Now coming to the management of the cluster headache, I already told you, management of tension headache. So tension headache, positive finding would be in the tension headache. What could be the positive findings in the tension headaches would be? Let me briefly tell you about the tension headache, what positive findings you could have in the tension headache. So in the tension headache, the patient might tell you that recently he or she had a problem at home or at workplace or somewhere, there is a more job load is going on in their life. That would be the tension headache problem that can be there. And what would be the treatment in the tension headache? So relaxation techniques. So how would you say that? Okay, Michael, I'm going to offer you some talking therapy. Michael, I know that you are going through a lot of stress of your work, but sometimes you have to prioritize your life, your health as well. I know you recently been promoted to the manager's post, but sometimes it can give you headache. It will take time to get adjusted with the environment. But at this point, I would like to tell you, relax yourself, go out sometime, do some family therapy, try to go to the beaches if you could, get 1 or 2 days off. Maybe if you're feeling too much burnout, take some days off from your employer, take some annual leave. Is that possible for you? Yes, well done. So medication, don't worry, I will give you some medicines. Like I'm going to give you, I'm going to advise you take some ibuprofen and paracetamol over the counter. You can get it, because if somebody is going to get ibuprofen, you're not going to give ibuprofen, paracetamol. They can buy it from the over the counter. So yes, you can get only ibuprofen, paracetamol from Tesco or any of the pharmacy. And I would say, speak, don't bottle up your feelings inside your heart. Speak to your partner, speak to your family, and even you can get our sport for the talking therapy. What would they do? They will talk to you about your problems and offer you stress relief services. So your GP can do that. Hangover headache. So in what would happen in hangover headache? Anybody knows what is hangover headache? Hangover headache is very common, and if you are on the weekends, usually you will see some of the people coming to you with that type of headache. And how will you get to know that it's a hangover headache? So there are a few of the clues they will give you about the hangover headache. You will start your history in the same way. You will start your history in the same way, but when you will rule out everything, you will rule out rash, temperature, neck stiffness, a problem with the light, weakness, everything would be negative, negative, negative. When you come to Mactosa, doctor, I drink a lot. I drink 20 cans daily. Yesterday, oh doctor, I didn't know that. Oh, I was in club. I drank 20, maybe cocktail or something like that. They will tell you, doctor, and even they will act like that they are under the influence of binging or drinking. Yeah, definitely binge drinking. So again, you will follow the eyes and everything. But when you will examine, you will tell everything. If you know it's a hangover headache, but still you will rule out everything. When you will come to the hangover headache, happen when you drink more than your. So you will explain, Michael. At this point, I got to know. I would like to explain you are going through a condition we call it hangover headache. What happens when you drink excessive alcohol that your body can't handle? In this way, you can have this much severe headache. And you also mentioned that you are going to be more often, and you seems a bit dehydrated as well, because alcohol itself can cause dehydration. You will relate it with the positive finding, and when you will be managing it. So Michael, at the moment I'm worried about you. I think I need to hydrate you. Is that possible? You drink plenty of water, you rehydrate yourself with that water. And if the A&E setting, you can think of liquids or something. Just try to drink from the mouth. And what advice you will give him? Alcohol services. Michael, you mentioned that you are drinking this alcohol from so long period of time. But would you like me to offer you some alcohol cessation services if you're happy to do that? No, doctor, I will think about that. Okay, no problem, Michael. But you will speak to your GP, or you will speak to us again. We'll offer you that service. Okay, Michael. The next point, what you will tell doctor. So what we will say, leave advice, what treatment you might give to the patient. So you will control hypoglycemia. You check the blood sugar in management plan. So that is sugar is not low. Advise him eat more, because drinking more alcohol can cause hypoglycemia. Offer him some vitamins. I will give you some take-home vitamins so that you will drink, because drinking too much alcohol, the vitamin level can go down. So you will tell about that and give drinking advice. I would like to give you some reading material so that you will know more about hangover headache and alcohol cessation group. Yeah. So well done. So now coming to the carbon monoxide poisoning. What would be that? Let me tell you what would be that anyway. So if somebody is having carbon monoxide poisoning, what would happen? So in carbon monoxide poisoning, if anyone know the scenario of the carbon monoxide poisoning, from here, I will simulate as a doctor, and you can simulate as a patient if you want. Otherwise, few of the doctors would be coming soon. Dr. Mariam is coming, Dr. Ramesh is coming, few other doctors would show up today. They will do the simulation anyway. So when they will come, I'll do one simulation from myself, and they will come. Okay. So I would like to. So Noor, basically, you mentioned about different approaches. So guys, basically, my main focus is to get you to expose you with the difficult approaches in the start. So today, I know I'm doing more of the medicine part, but I will do one scenario myself from any of the difficult approach. However, we will not be teaching that approach now, but I want to introduce you about that approach, like difficult patient, medical error, refusal structure, confidentiality structure, and we will be sending you soon. So in the middle of your, like today's second day, but soon we'll be sending you ebook for the history taking and everything. I will be sending ebook for all the approaches, like 17 to 20 approaches. That will be an ebook. So everything would be there on that approaches. You have to apply that approach to MLA or PLAB presenting campaign, and you will get through. So because there's a 20 to 22 approaches, we're creating an ebook. Please do cases too. Fatima, thank you very much. We will do the PEDS cases, but according to our list, I think it's day 3 or 4, 4 or 5 days. So we will do that anyway. So for now, and as we are running over first course at the moment, so we made few of days, like first 2 or 3 days, open days, that people would see that how we are teaching, and the people will get to know that how we are doing it in terms of simulations and algorithms, so that people will find out. So after this whole of the headache, I will not give you more headache. I'll give you 10-minute break. So I know you are here from 9:30, 10:30, 11:30. So I will give you break after this. So now coming to the part of the carbon monoxide poisoning. So in the carbon monoxide poisoning, basically what would happen? The patient would say, the doctor, whenever I go into the home, I feel that I'm having headache. So there would be some cooker problem, or their colleague would have the same problem as well, or the roommate have the same problem, headache. So then you will take the detailed history of headache, how you have done it. Then you will take a detailed history of about house. Can you tell me more about your house? How many windows? How many is the ventilation system is okay? Anyone else have the same problem? Any skin changes and the thing? Then after that you'll do that. Okay, if the oxygen saturation is low, you give them high oxygen. If not, that's fine. And you'll say that I would like to do your ABGs, blood gas. If it's an A&E setting, definitely it would be A&E setting. I would like to do your blood gas. The blood gas is okay. Definitely they might not give you results. Then you will give some advice about carbon monoxide poisoning, that we will offer your occupational therapist, that they would check your get your landlord to ask to check the cooker or the heating system. That would help you. And you do ask about carbon monoxide alarm is functional or not. So they need to get their carbon monoxide alarm functional. High flow oxygen you can offer. You can tell them they can walk in the park. You can give them paracetamol as well because they have the headache. So don't forget paracetamol. Wherever you forget anything, think about paracetamol. You can give paracetamol but do ask about the time. Management of subarachnoid hemorrhage. So in subarachnoid hemorrhage, what would happen? In subarachnoid hemorrhage, when I was doing that scenario with Zahra, the patient will not let you go further until you will give some good pain relief. And the patient would say the pain goes like this. In 2 or 3 minutes, my pain go very high. It's not bad like they will not give you any of the symptoms which we have discussed above. So no rash, nothing. Only thing they would say it might be high blood pressure or it would be the worst headache of my life. So will you do CT scan or not? Yes or not? Will you do CT scan or not? Hasham, Saban, will you do CT scan or not? Yes. If you are suspecting subarachnoid hemorrhage, do the CT scan. Now, coming to the management plan. Same history, same data gathering, everything is same. So, if the CT, if even they don't give you finding of CT, you'll tell that, Michael, at this point, I'm thinking there is something serious is going on, and it is called a subarachnoid hemorrhage. And common type of stroke caused by bleeding on the surface of the brain, Sometimes it can be potentially dangerous and fatal, but don't worry, you are at the safe place. What we are going to do now, I'm going to order a scan of your brain, scan of your head. I'm going to scan your head. Is that be okay with you? Which will tell me by any chance there is any minor bleed over there. Then explain. In the best case scenario, the CT scan results come out fine. Then it's totally fine. Then we'll discuss plan. If the CT scan results come out fine, that means your CT scan is okay, that we might need to our medical team, speak to medical team, or sometime radiologists do recommend of lumbar puncture, that there is another test in which they will put a needle in your back, because sometimes the small subarachnoid hemorrhage might miss on the CT scan. So we do recommend to get the lumbar puncture done. So if we do the lumbar puncture, that would be that case. If, for example, if the CT finding highly suspicious and positive for the subarachnoid hemorrhage, we need to speak to our neurosurgery team. What the neurosurgery team would do, they might start you on some medication like nimodipine, and we might give you some fluid. We'll keep you in the hospital until the neurologist would come, a neurosurgical team would come, or take you in their ward, and we'll make sure you'll get advocate and analgesia and pain relief. So you will manage that in that way. Okay. Any questions, guys? Any questions? Guys, if you don't enjoy the session, say yes. If you're not enjoying the session, say yes. I don't want you to say yes or no. Say yes. If you don't like the session, say, Khadija, you are here. If you have any question, Khadija, you can ask. Okay, so you said yes, you're not enjoying. Okay, well done, guys. So this is how you will do the subarachnoid hemorrhage. Now, management of GCA. After that, guys, I'm going to, after this sketch, I'm going to show you, after the break, I'm going to show you different scenarios from the headache. Okay? Okay, so management of GCA. How would you know? What would be the presenting complaint is a GCA? So the presenting complaint for the GCA would be, the patient would say, doctor, I'm having pain here on my temporal area. And I can feel, when you feel that there would be some tenderness over there. The positive finding would be some tenderness there. If you're 100% sure, so what would be the investigation you would send? Examine, you have to verbalize that. You would say, I would like to send some blood marker, infection marker, or inflammation marker. What is inflammation marker? I would send ESR. ESR might be raised. And if there is 100% suspicion of GCA with eye symptoms, if person have the eye symptoms, you will refer straight away to the patient. You refer straight away to the eye specialist for the GCA. If the patient don't have any eye symptom, again, you will treat him in the hospital. You will treat him. When you are suspecting GCA, you have to start high dose steroid and some other medication like aspirin, and you have to give steroid cord. And you will tell them, I'm going to refer you. Yes, Fatima, everywhere you need to mention. I'm going to see the front and back of your eyes. Don't say fundoscopy, say front and back of your eyes. Okay, refer to the rheumatologist. So until you're being seen by rheumatologist, Michael, I would like to tell you, you need to continue your steroids. Okay, because why you need to continue your steroids? Because this condition is potentially dangerous. The ultimate treatment for that is steroid itself. And please, I would like to safety net you about that. Please don't stop taking steroid until being told by any specialist. We will taper it off slowly. So this is, then what would be the advice leaflet? You can give this advice leaflet: headache diary for every headache, GP follow-up for every headache, reading material for every headache to know more about the specialist referral in the subarachnoid hemorrhage and GCA. GCA specialist referral is rheumatologist or